Depending on when you listen to this lecture, you may have already had a chance to practice ultrasound in lab. And if you work as an aide in a clinic, you've probably done ultrasound a lot. Maybe if you work in a clinic that does ultrasounds. So we are going to talk about the theory behind ultrasound and, of course, review the indications, contraindications, and precautions, and some of the terminology associated with ultrasound. So the learning objectives for this section, I want you to be familiar with the terminology that's listed in the Chapter 9 glossary. In the 6th edition, it's on page 198. If you're using the 5th edition of the book, I'm not sure what page it's on, but it's at the end of Chapter 9. And we're going to talk a little bit about the relationship between frequency and depth of penetration of the ultrasound wave. So sound, any sound, not just ultrasound, is a compression rarefaction wave, and we'll talk about what that means. Ultrasound is sound with frequency above 20,000 hertz, and normal human hearing is between 16 and 20,000 hertz. Therapeutic ultrasound is between 0.7 and 3.3 megahertz. So that's millions of hertz. So it's way above the range of normal human hearing. We can't hear ultrasound, obviously. You can use it for heating, thermal effects, or for non-thermal effects, which are cellular effects, which obviously you can't feel that. You can't feel cellular effects, but it does have some proven effects. The sound wave is formed by what's called the piezoelectric effect. There's a crystal in the ultrasound head that's a transducer that converts electrical energy into sound energy. So the crystal's usually made of plumbium zirconium titanate, which is a synthetic crystal. It's very cost effective and efficient, and it has those piezoelectric properties where it converts electrical energy into sound energy. Alternating current causes expansion and contraction of the crystal, so vibration of the crystal at the frequency of the current. The expansion compresses the material or the air or coupling material in front of the crystal, and contraction rarefies or decompresses the material in front of the crystal. So you get little waves where it's compressed, rarefied, and it does it at the frequency that the crystal responds to. So when ultrasound manufacturers are making those crystals, they choose the crystals that respond to certain frequencies. The sound wave created by the crystal is caused by the expansion and contraction or compression and rarefaction of the material in front of the crystal. The piezoelectric crystal also refers to the part of the ultrasound unit that contains the crystal, which is also known as the transducer head, and that's the part that we're touching to the person or to the coupling medium. The sound wave or vibration energy is transmitted to tissues, causing compression and decompression of the molecules in the tissue, thereby sort of vibrating the tissues and producing therapeutic ultrasound. Multi-frequency transducers use a single crystal which vibrates according to applied high-frequency alternating electric current. So it depends on what frequency you pick, how much alternating current goes into it. And that is all built into the unit that the manufacturer provides for ultrasound. And all we have to do is press the buttons and pick which frequencies we want, which is pretty handy. So the power, when we refer to power in ultrasound, it's expressed in energy per unit time. So it's expressed in watts. The intensity is the rate at which the energy is delivered per unit area of the sound head. So when we talk about it, we say watts per centimeter squared. So it's the power per the area. Power over the area. The range for therapeutic ultrasound is 0.1 to 3.0 watts per centimeter squared, and that's what we're going to document as our intensity in our documentation. We want to use the lowest effective dosage, just like everything. Everything we do, we want to use the lowest effective dosage. So the output over the area of the transducer head, it doesn't send out an even wave. Like in one of those pictures, it looks like it's an even wave coming out, but it's not. It's this jiggity jaggedy thing that is depicted here. So when we talk about the power, we talk about the average intensity of ultrasound output over the area of the transducer. And that's the spatial average intensity. The spatial peak intensity is the maximum intensity at any point in the beam. It's usually greatest at the center of the beam and lowest at the edges. The beam non-uniformity ratio, or BNR, is the ratio between the peak intensity and the average intensity over the space of the transducer head. The 6 to 1, so 6 peak to 1 average and lower are acceptable values. So we get in the labs, we get our equipment serviced every year, and we just had the technician come and service our equipment. And most clinics do the same thing. The hospital-based clinic where I worked, they had a biomed team that serviced all the equipment. Some private clinics have a private company come in and do it. And basically, they come in and test all your equipment and make sure that it's working properly and that the beam non-uniformity ratio is acceptable. If it's not, then you have to retire the unit. The effective radiating area is the area from the transducer that radiates ultrasound energy. It's never the whole face of the transducer. It's usually a little bit less. It's smaller than the area of the transducer because of that non-uniform vibration of the crystal. So if you have, let's just say you have a 2 centimeter transducer, not all of it is going to be effective radiating area. And the effective radiating area, or ERA, is always smaller than the total face area of the transducer. So if somebody asked you that on a quiz, you would know the answer. The frequency is the number of compression rarefaction cycles per second, or hertz. So how many cycles per second? 3 megahertz. So it's 3 million cycles per second. It's a lot of cycles per second, right? It has a more superficial effect. It penetrates 1 to 2 centimeters. So you can think about the tissues in the body and what you might be treating and what might be affected in the first 1 to 2 centimeters of depth in your body. So if centimeters don't make sense to you, 1 centimeter is 1 inch is 2.54 centimeters. So a 3 megahertz frequency penetrates about an inch. That's helpful to you. 1 megahertz frequency has a deeper effect. So lower frequency, deeper effect. Frequency and effect are inversely proportionate. And that's about 3 to 5 centimeters, which is about 1.5 to 2 inches. So think about where the tissues are in your body and what it's going to affect. Increased frequency causes increased tissue friction and absorption of energy, therefore decreasing the depth of penetration. So depth of penetration and frequency are inversely proportional. Lower frequency penetrates deeper, higher frequency is more superficial. So this is our little picture from the book, which is really helpful because you can picture, lower frequency is going deeper down towards the bone, and higher frequency is more superficial. So if you're trying to target a particular tissue, keep that in mind. Ultrasound attenuates, which means it gets less. Just like sound, any sound waves, regular sound, audible sound, attenuates as it goes out. So if I go out in my front yard and I yell, the neighbor across the street's probably going to hear me. Maybe 2 houses down, they might hear a little bit, and then 3 houses down, they're not going to hear anything. So sound attenuates and ultrasound attenuates the same way. When it when you're applying ultrasound to tissue, some of it is absorbed, and that's the greatest influence in attenuation. Some of it is reflected, and some of it is refracted, where it just bounces off. The higher tissue density, like collagen, and higher frequency is greater attenuation. Collagen tissues tend to absorb more ultrasound, so ultrasound can be a good treatment for tissues that have a lot of collagen. So think about what we've talked about with tissues, and which tissues have a lot of collagen. Those might be good tissues to treat with ultrasound, depending on what your indications are. The sound waves enter the body and are attenuated by absorption, so conversion of mechanical energy of ultrasound into heat. Sometimes when we're going for a heating effect, that's what we want. Higher tissue density, like collagen, and higher frequency is greater absorption. So collagen tissues absorb more ultrasound energy. Reflection is the redirection of the incident beam away from the surface at equal and opposite angle to the incident beam. So bone, it reflects right off bone, like right back at you. The transmission medium, whether it's gel or water, reduces reflection. And then refraction is where it bounces off and goes in different directions at a different angle. So air is not a good coupling medium, because the ultrasound is just refracted into at different angles, and it doesn't get absorbed into the tissues at all. So we always need a coupling medium, gel or water, in order to apply ultrasound. So the parameters that we are going to record in our documentation: the intensity in watts per centimeter squared, the frequency in megahertz. So it's either going to be 1 or 3.3 megahertz. The intensity is going to be whatever you turned it up to. The duty cycle is the percent of time that the ultrasound is on. So 100% duty cycle, that's continuous ultrasound, and it's on all the time. It's on 100% of the time. At a 20% duty cycle, it's on 20% of the time and off 80% of the time. That's a 20% duty cycle. There's a lot of research at 100% and 20%, and not so much at 50%. I don't even know why they have that as a setting on the machine. But usually when we're doing non-thermal ultrasound, we do it at a 20% duty cycle. So it's on 20% of the time. And in the 80%, that gives the tissues time to cool down, so you don't get a heating effect. You just go for the non-thermal effects. The effective radiating area in centimeters squared, and the beam non-uniformity ratio. And normally in our documentation, we record the first three, and we don't record the ERA and the BNR. So how superficial or deep are we going based on the frequency? Are we doing it thermally or non-thermally based on the duty cycle and the intensity? And we'll talk about how to determine the intensity. You probably, if you are watching this after lab, you probably already know that now.